Yes, I'm based at the hospice in Cambridge, and I also work 1 day a week in Addenbrooke's Hospital, which is really helpful because often these patients I will see in both settings. We've been offering advanced care planning discussions and document creation probably for about the last 6 or 7 years now, and I see a whole range of patients, including people with MND, dementia, progressive supranuclear palsy. I've written plans for patients with heart failure with implantable cardiac defibrillators, COPD, lots of conditions. But today, obviously, we're going to be talking about my experiences and the experiences of the hospice and other staff in thinking about advanced care planning for this patient population. So the aim of the session today is to reflect on your current practice, consider how we're going to plan, how we plan ahead with people, consider when, and I've got some practical sort of suggestions and things I've learned from my practice, because I started off without having never done this before and have gradually gained quite a lot of experience over the years. And now, in a way, we're trying to pass it on to say, well, can I hand some of these discussions and this document formation to the MS nurses and to other professionals who are involved in the care of these patients. And then we're going to have to think about, and this will go on, I hope, after the talk, what you can do with your practice and what goes on in your service areas. So the first bit of the session, okay, I want you to turn to your neighbours and think about the following questions, and then in a few minutes I'd like you to sort of shout out at me and tell me where you're at, because I'm aware everything is so different in different service areas and regions. Talk to me.
We don't have any pictures of those. We can feed into them, but we don't let you discuss. Yeah. You haven't used it. Just multidisciplinary, also not being not familiar with my come away from these things and it's really this like I'll do it all. Yeah. It helps. So it was trying to probably out. It's really wanted to. So she's at the time. She was really what we want to do with these patients, and we would end up with them in hospital. So we started to talk to Lorraine. Just a bit more inclined to have those discussions about having thought of it. So as part of our review, what we have we thought about the future, that might be a hospital plan, who's going to look after you if your husband is well, or it might be having it at will, power of attorney. If they take up on those questions, you can then think, actually some people like to write it, if they completely shut it down. And also she's going to go through what happens.
Yeah. So does she help you with like continuing healthcare and things?
So yeah, we would do that.
Yeah.
Work with the people who do considering healthcare, yes.
Lots of discussion, as I thought there would be. Okay, so first question is, to what extent do you discuss advanced care planning? Lots? Yeah.
We were saying here, because I'm in the community,
Yeah.
and my colleague is in hospital, both of us have got background in palliative care, but I have more conversations because I think hospital's more CMT orientated.
Yeah.
Now, and in the community, we're seeing a lot of the people that aren't able to get to the hospital on DMTs and are more progressive, I think. So I probably have more of the conversations than perhaps my colleague next to me who doesn't have them particularly.
Yes, but who might be very willing, but you're in a different setting,
exactly. That's
maybe a slightly different time in the illness. Yeah. Any other thoughts?
We were just saying it's quite important. It's a conversation to have really early on, because as MS nurses, it can be too late.
Yeah.
So it's a conversation to put plans in place early on so that wishes of the patient, they can have the wishes.
Yeah. Okay, and do you have any particular documents that you use in your region? Yeah, do you want to just shout them out? What have you got?
Hi, I come from Suffolk. We do have a set of documentation that everyone uses throughout, so community nursing, and everybody's recognised by the ambulance service, and everybody knows that that's what the documentation is, so it includes a DNAR, but also all their advanced wishes and so forth.
Okay, is that a respect document, or is it something?
We call it a My Care Wishes folder.
My Care Wishes.
So
Okay.
So it's got everybody's contact numbers and everything, so everybody knows who's involved as well if things go wrong.
Oh, lovely. So quite a well-developed document that's recognised by
It's
everybody.
only as good as how much information is written on it, of course.
Yes, yes. And have other places got things that are regional that respect? Yeah, we've got respect coming out. CMC. Coordinate My Care. Yep. Okay, and what sort of things do you cover in these documents? Because it sounds like probably it's a range of treatment decisions, might be around care, might be around what type of care people want. Other things that you might cover? Where you want to be, where you want to be cared for. And do they cover advanced decisions to refuse treatments? They might do too. Okay. So actually quite sophisticated then in terms of all the different things that you, in some areas, are quite, have got things. Others perhaps more fragmented, and certainly in Cambridgeshire, we've got the community DNA CPR form that's about to be replaced by Respect. We've got various different electronic systems. Most of the GPs are on System 1, but some are on EMIS. So we've got quite a lot of different ways of documenting things and different systems that don't necessarily talk to each other. So what do you think needs to be improved in your regions? What can you do better? Or do you feel like you're covered?
Communication between the community and the hospital environment. Because very often they do have documents what been made in a community, but they don't bring them to the hospital.
Okay.
Or the hospital settings is just losing them on the way.
Okay.
After the mission.
Okay. So documents only as good as what you put in it. Documents only useful if it's communicated across all the different areas that a person might find themselves in. Okay. Well, that's actually really encouraging to hear that things have changed a lot in recent years. That's not where we were, certainly when we first started. So, as I'm sure you know, good advanced care planning should cover a whole range of things, all to do with the patient, and that's everything that's of pertinence to them. And we know that it's a good thing, you've said that, and there are various studies, and these will have been done in lots of different populations, and we can look it up, look and do a search, and there's lots of good reasons to think about why we should think ahead, and lots of reasons why things don't happen, though, and regrets if people don't think ahead. So what kind of things can we cover? Well, a whole variety of things, from family matters, thinking about what does illness do to relationships, what do I need to think about. Very practical matters, which again I'm sure you're all involved in, about housing and adaptations. Lasting powers of attorney, which we're going to come back to. And then planning for end-of-life care, which of course isn't going to be relevant right at the beginning of somebody's diagnosis, but in the later stages. And then things that might happen after death, wishes after death, and things like post-mortem donations. So lots of these ways of planning ahead are normal to all of us, living with illness or not. In terms of where we get involved, I tend to get involved at the specialist end. So when somebody has got quite strong views, has been identified either by Mary and her team, or perhaps they're coming to our day therapy service, and they've been identified as wanting to take things further, really wanting to explore what their thoughts are about treatment. It's mainly about treatments in the future and place of care. Up until that stage, the GPs can be involved by writing or putting the patient on the gold standards framework, using the various end-of-life care templates, and everybody can be involved in advanced care planning discussions, talking about progression, getting a sense of where that patient is at in their illness and their general care wishes. So I will see and my service will see a small proportion of self-selecting patients who want to talk about the future. And I realised that there are some patients that will never talk about it. No matter how hard you try, they will not go there. So what's the point of writing these or getting people to think ahead? And some of the arguments against any of these documents, whatever shape or form they might come in, is that they're too ambiguous. And certainly if you ask somebody who's in good health, what do you want for your treatment for the future, it's very hard to predict things that you've never been through. And that can be the same if you're living with MS and you haven't experienced a hospital admission for a complicated sepsis, or you haven't had seizures or other things. And it can be quite hard, therefore, to write it well. And that's where we come in, because you want to write a document that's going to be helpful. The other thing, plans might be ignored by doctors. They might be forgotten by patients. So what's the point, as we said, of having a plan if it's not used or it's lost? What about LPAs? Well, if I appoint an LPA, isn't that good enough? And perhaps it is, but for certain people, perhaps it's not quite enough. And actually, there's no real choice. So we give patients choice, but in reality, is there that much choice? And do we even need them? Because if a patient's not going to lose competence, do we need them? Because at the end of the day, an advanced care plan is usually put in place because you're going to be temporarily or permanently incapacitated. So clearly, I don't believe that, otherwise I wouldn't be standing here today. Because I think for this population of patients, we can write very disease-specific and treatment-specific plans because somebody's already living with an illness. And it's about timing, of course, and it does become easier to predict the future when something begins to change, when there is a decline in health. And often that's the prompt to start thinking about the future. And I'm sure in your practice you'll have an idea of when and which patients you think, okay, we ought to start mentioning something, even just testing the water gently. Or other times where you think, well, we've just got to go there because this is changing very quickly and very soon we're going to need to know what this person wants. Are we doing what's right for them? And it does take skill and practice, and I think when I first started, the documents I help people write are very different to the ones I write now. The ones I write now with patients are very much more nuanced and very much have more of the patient's voice in them. And I teach my registrars to write them, and we have a clinic now which runs every couple of weeks to do advanced care planning and with patients, including patients with MS. So we have to think of the plan as a live document and share it, and it might change over time, and we might want to come back and have a look at it again. And it can complement an LPA, and we'll come back to that. And okay, it's not unlimited choice, but there are some choices about some things at certain times. And the thing is that these patients may well lose capacity at some point in the future. So NICE guidance suggests that first of all, you should talk to patients with MS, living with MS and their family members or carers about the possibility of cognitive problems, and that you also should talk to them about advanced care planning and power of attorney. Okay, so the question is when? Okay, so that's a very general list, but what about for the patients you see? Are there more specific things you'd add to this list? Or specific times or conditions? Any takers?
When they raise it.
Wouldn't that be lovely? Yes, when they raise it, absolutely.
Cognitive changes?
Cognitive changes, absolutely, or preferably before, or at early stages. So all of this, ideally, if you want the patient's voice, you want them to be cognitively able to think through all these complicated decisions in the future.
Patients with motor neuron disease?
Yep. So,
They tend to progress faster, most of them.
yeah.
And also, I have a question to you. Has anyone raised any question regarding Dignitas?
Yes. Yes.
How do you respond to it?
I will come back to that. But absolutely, that's in one of my slides. Yep.
I was just going to say, to make things easier, when you start treatments, that might be the time to even introduce excessive withdrawal, because then it's not shock.
Mm-hmm.
And it's something that you've talked about
Yep.
rather than in between.
Yeah, so almost making it standard practice. If you are going to offer a treatment, a medical treatment that's potentially life-prolonging, a person has a right to withdraw that treatment in the future. But if you don't tell them that, they don't know that. So it's fairly standard practice in people with MND who are going on to non-invasive ventilation to have a conversation about the fact that this can be withdrawn. And again, over the past few years, we as the hospice, get involved in people who are withdrawing their NIPI, who may or may not be close to dying. So if we could almost make some of these conversations standard practice, that would be wonderful. If we could plan far enough ahead, within reason, then that would be very helpful. And it could be with say, recurrent infections, recurrent admissions into hospital, when people change venues, so when they go into a nursing home, that's often a prompt to have a discussion. When they come into hospital with a respect document, everyone's being asked now about their ceilings of care and their DNA CPR status. So it's almost becoming standard practice for that to happen, to then continue it perhaps and make it more specific to the person, not in the acute setting. Okay, so what's our role in all of this? And I think we have quite a few roles. And it really is about providing that disease-specific information with which to base their decisions on. And we know that they might not base it in any way on their illness, and in a way, assisted suicide is one of those, that often people have a very strong view about assisted suicide regardless of their illness. But we are there to advise them. We're there to create, if we're going to help them write a document, especially if it's an advanced decision to refuse treatment, you want to make it legally binding and watertight without any fear that it won't be helpful or it will cause confusion. And my standard is, presume that you are a healthcare professional that's never met this patient, but you are being called in an emergency. Can you follow this document and know that A, you're doing right by the patient, and B, that you're not going to be sued? So that's your standard. Okay? And we're also provided evidence that the patient's competent at the time, because once these plans are in, people ring me up and say, we've got this patient in A&E, we know they're known to the hospice, we've got their plan, is it okay, can we follow it? Is there any reason, to doubt that they're competent? And I can say, well, actually, they're completely competent when they wrote it, and I've got that entry, and it could be a number of years ago, that this was done. And even if we don't end up writing a document, it doesn't matter. It's the fact that we've had the discussions with the family and the patient. And that can be enough, and that's where people are very happy to stop. They don't need anything formal, they've just opened the door. And then the last thing is disseminating the document. So we have a system which works okay of what to do with the document, where to send it, how to get it to the Addenbrooke's notes, how to get it onto the computer system out of hours. Okay, so the process. Now, I'm aware that I have the luxury of time. I have an hour to talk to people, and very much I know in a hospital setting, in a clinic where you've got 20 minutes to do everything, you're not going to be able to do this. Or maybe you can, but it will be over a number of different consultations. And actually, I might advise that this is something that isn't a one-stop shop, and I will have multiple conversations with people. The longest time it's taken for someone to sign an advanced decision to refuse treatment combined with an advanced statement is 1 year. I did it with a gentleman and his partner, and a year later he sent it back going, okay, this is okay. So I will start the consultation, really, find out where you're at now. I know we do that, but it's sort of, in a way, I've just been thinking, what is it that I do that starts the ball rolling? And ascertain the motivation for the discussion. Why now? If someone's starting to talk to you about the future, why now? What's prompted this? Because it is a big thing to think about. And it's also hugely emotive. So whilst I'll be saying we're going to have some really detailed discussions about treatments, and I'm going to make it very, talking medical language, but I know there's a person at the end of it, okay? And I know that this is going to be really hard discussing some of these things, especially when you're sensing conflict or different ideas. So I will give them some information. So what do we need to tell people about advanced care planning, okay? So here's when we come back to that, I'll come back to that, but yes, sometimes the motivation is about wanting to end life. And, for example, the campaign for dignity in dying, well, it will often be, and the cases over the years have often been, people who are living with motor neuron disease, less so perhaps with MS, but, it is out there and it is an option. And the other thing I think we will see more often is people who are voluntarily stopping eating and drinking. And we had our first gentleman who did that, a gentleman with MND. who we supported his symptoms at the end of his life when he voluntarily stopped eating and drinking because he didn't have anything else that he could do. There was nothing to withdraw. So I'll come back to how to approach that. So you know that there are some patients who are living in the moment. That's how they live with their disease. They don't think about the future. Perhaps they never have, actually. This isn't new. This is their personality. And they might want to plan ahead a little bit, but it could just be, well, I'll write my will, and that's it. And you know what? The family know what I want, so don't worry about it. And then you're sitting there thinking, okay, but I'm watching this relative's face, thinking, you really want to plan ahead, because, in fact, you're recognising that you're going to be the person in the future when something happens, you're going to be the one calling 999, and the paramedics are going to turn to you and say, should we admit? Or we're going to admit, and you're thinking, I don't really want them to be admitted. You know? So over time, you can imagine this dual living in the moment, planning ahead can certainly change over time for one person. And it can be very different when you're sitting in a clinic with somebody between the people in the clinic, how much either of them wants to plan ahead or perhaps not at all. And it's often not about dying, actually, although a lot of my work is around patients who are dying, it's about living. And it can often be about not wanting to be given up on. So often the motivation is, I went into hospital, I didn't get the care that I wanted. It was really hard because often, you know, one-to-one care at home, busy acute hospital. But I felt my wife, or maybe they can't remember because they were delirious, my wife really had to fight for treatment. And I've heard that story recurrently. You know, I really felt like I had to every single time fight for antibiotics, etc. So you have very different motivations and experiences as to why now and why people want to plan ahead. So what kind of questions do I ask people? So apart from that starting point, where are you at? And to say, you know, we're here today to talk about the future. You know, are you someone that likes to plan ahead? And Atul Gawande gave some lovely talks, Reef lectures a number of years ago, and he said these are the 4 questions that you ask people. Now, you're going to, of course, we never stick to a script, and we all approach conversations differently. And so I kind of changed these slightly, you know. So what are your fears and worries for the future? I'll often start with, are you someone who likes to plan ahead? Do you worry about the future? Is there anything that you're concerned about? What are your goals if time is short is often not appropriate. As I say, that's not necessarily the focus of what's going on here. But what makes your life go well? You know, what do you mean by your quality of life? Because that's what the language that people use is quality of life. Now, as doctors, we're not allowed to judge somebody's quality of life, but that's what people feel is happening. What we can judge is what effect does our treatment or non-treatment have on that person's quality of life. And that's a slightly different way of looking at it, and that's an acceptable way of looking at it, and in fact how I will coach people when I'm having these discussions. So really, what's most important to you? You know, what am I going to make this decision on? Do we give this treatment or not? And how do you feel your quality of life is now? And what about in the future? And then his other question is, what outcomes would be unacceptable to you? And I think that's a good question. What would be absolutely unacceptable or intolerable, or something, you know, you wouldn't want, that you would feel your quality of life wasn't acceptable to you? Okay. And that's your line in the sand. And I find myself saying that, you know, tell me, what do you have a line in the sand where you think that, okay, at the moment you want all of these treatments, and we'll make sure that we document that, but there might come a time when you're thinking, you know what, this doesn't feel right. And actually it would be okay not to have all of these treatments or some of these treatments. And you can get sometimes you get a really good response. I'll be, well, and surprising responses as well, some really quite surprising ones, and think, how can you work that into the document? And others don't. You know, it's a nebulous thing. They don't really know. So these are some of the things I say to people. If you feel very strongly about something, and it's a treatment you don't wish to have, you need to write an ADRT. Because you can have your LPA for health, who has to act in your best interests and can't be motivated to shorten life. But if you really feel strongly, you write it down, because that's your voice. If you can't speak for yourself, or you're too unwell, that's your voice, and we have to follow it, and it's legally binding. You know, it's about treatments you do and don't want, so it's not just negative. You know, that's not, as I say, it's not just about dying or withdrawal of treatment. It's about all the things you do want, you know. Yes, it's a clinical decision. You can't demand a treatment in advance, but you can be open to a treatment if it's clinically appropriate. And that's as important as knowing what you don't want. So tell me everything you do want to the point of things that you don't want. Because as a doctor, I want to know both, because that's telling me where to stop. Okay? And then there are other things I find, you know, family saying, actually, it's family going, you know, am I going to say the right thing? You know, and what would they ask you if you were able to wake up and tell them? And it is the burden on family. And I did have a lovely registrar, I was teaching some registrars, and he said, you know what, this isn't about the patient at all, it's about the family. So why should a patient do any of this when at the end of the day, you know, it's actually about the family? And one of his colleagues said, no, you know, it's awful for the families having to make these decisions, and it's awful if someone doesn't write a will and someone dies intestate. And you know, it's actually, we are a family, we are not alone, we are not an island, and we come with a family unit in some shape or form. So whilst you cannot force people to do it, it's thinking why. It's not just about you, it might be about your family. And if you are someone that likes, you know, that you are looking out for your family, this could be one of the ways to do it. Okay, so I'm sure you know all of this. Okay, so you can't refuse basic care, can't demand anything illegal. You can refuse treatments in advance, and if you write it correctly, it's legally binding. Can you say you don't want to go into hospital, or why can you not say I don't want to go into hospital ever in an advanced decision to refuse treatment? Do you know why? I've actually written it slightly incorrectly on the slide. Is hospital a treatment? It's a treatment you get, absolutely. So often patients will say, I absolutely don't want to go into hospital. Yeah, that's great, I can see that. Hospital itself, I can't write, I absolutely do not want to go into hospital ever. Because they could fall over and fracture the neck or femur. And hospital's absolutely the place of safety. So we'll have a conversation about, I hear what you're saying is you don't want all the treatments in hospital. You absolutely want to avoid hospital at all costs, but for the unexpected, I appreciate that hospital may be a place of safety. So I might write that into the plan. You know, do your utmost to keep me out, but I know it's not a given. Okay? Best interest decision making. So if there is no lasting power of attorney for health, who makes a best interest decision? Who has that responsibility? Shout it out loudly. The team and the family. The patient in a best interest decision. Okay. All right, I've got IMCA, family, patient and family. So if it's a best interest decision, if you've got to the point where someone's incompetent, there's no lasting power of attorney, but you've got family. So if they didn't have family, you'd have an IMCA, absolutely. The person who gets to make that decision is the clinician. So it falls to the doctor with the input from the family about the patient's wishes, thoughts for the future, what's important to them, any expressed ideas that they've come up with before. So all of this, though, will be taken into account, but ultimately it's the treating team that decide. And where there is a difference in opinion, they get a second opinion. Where the family absolutely can't decide, it will go to court. Now, when it gets to court, a friend of mine who's a barrister who's involved in medical legal cases says that the courts really will take very much a best interest approach and will very much try to take the voice of the patient. So they really don't like doing these cases at all, these medical legal cases where, you know, do you withdraw treatment, do you carry it on? So they will very much be looking for as much information about what that person would want. So if the take-home message today is, get people to talk about what they do and don't want. Even if it's not specific, tell me on what grounds, on what basis do you want your family to make that decision? Tell them what makes your life go well. Tell them what's important to you, because that's what we're going to need when we come to make these decisions. Okay, so what to cover? So I think, as I say, with MS, there are some quite specific things that we can discuss. From infections to deteriorations and specific Events, so acute events. So I've written plans for people who have seizures, trying to stay out of hospital. Ileus, we're writing one for a lady at the moment who gets a recurrent volvulus, so seeing how much we can try and manage that in the community. Block catheters, sounds quite basic, but this is when people end up in hospital when they don't want to be. Or we can think about treatment clusters, okay? So home-based, ward-based, going right up to ITU. So I either start at the top and work down, because I say, well, what are your thoughts? Have you thought about the future? What are your thoughts so far? Oh, I absolutely wouldn't want to be resuscitated. Great, let's start at resuscitation. Or I absolutely don't want any treatments. Okay, well, tell me what you mean by that. And often it's not that they don't want any treatments, they just don't want to be messed around with in some of the more intensive treatments. So you'll kind of tailor your conversation depending on those first few questions. And it, as I say, go all the way up to full intubation and intensive care. So here are some examples of things that I've helped people write. And as I say, I write them, I do all the typing, but it's based on the conversations. Okay. So the first little bit is to tell you about me. Okay. And then we've got a little treatment cluster. So I'll say to patients, if you're going to go into hospital and you've got an infection, so imagine a pneumonia or a severe urinary tract infection, you're probably going to need IV antibiotics, IV fluids. If you're struggling with your swallow and it's taking a while for you to recover, you might need feeding, and that's likely to be, well, it'll be an NG tube in the acute initially. And if your breathing gets really bad, you might need non-invasive ventilation. And so in a way, you kind of want to say yes to all of those, because this is potentially reversible. Therefore, you want to be given the best opportunity to recover. Okay. But what about, doctor, if I'm not recovering? I don't want this treatment to go on forever. Okay. So we might write something like that, saying, look, I don't know how long treatment will go on for, but what you're saying is then, and again, in a way, we shouldn't have to write this because we should be doing this as doctors, but sometimes it's actually quite hard to withdraw treatments that have already started. So it's giving, again, more information for the treatment team to help decide when it's okay to stop treatment, if ever. Okay, another example shows us the line in the sand. So I'll end up saying to somebody, okay, let's talk about your treatments as you are now. So if you've got a pneumonia tomorrow, what are your thoughts? In the future, if you are spending all of your time in bed, and you've told me that your line in the sand is that if you couldn't communicate with your family or you couldn't get out of your room, that at that point you're saying, I don't want treatment. So we can do a plan that's in two halves, the now and in the future. Okay. And here's somebody who, this is the beginning bit. So I will, as I said, I will do an advanced statement, things you do want and things you don't want, and weight it differently. So I'll often put whatever's it's got the most number of statements in it will go at the top of an A4 sheet of paper. So they'll end up with one bit of paper with all of this on. So these are all the things you do want, and be careful not to sign someone out of treatment for minor infections. So if you had a cellulitis that's not life-threatening, if you have a toothache or a tooth abscess, are you really saying you wouldn't want antibiotics at all? Because actually that would be really quite painful and affect your quality of life. But we do know that some infections might become more severe, so you need a clause there. Okay? So that's the beginning of, that's 2. If you look at what this person doesn't want, and number 5, that's that bit. So give me antibiotics, but if it's clear that I'm really not responding, do not take me to hospital. All right, that's my ceiling of care. Okay, so you're going to get these slides, and these aren't, it's non-patient identifiable, but these are the kind of things I write. And I actually have a document I'm very willing to share with you where I've collated lots of these, because I've just found there's some phrases that work well, some things that people accord with, or families come up with stuff. That's the lovely thing. You're chatting away, and actually the family has a really nice way of explaining something. So then I'll use that and work it into the document. And at the end of the consultation, I'm trying to work out, have they got capacity? Have they got enough capacity to write some of these things? And capacity is decision specific. So I might be fairly comfortable that they're able to say all the things they don't want, but I'm not sure they've got capacity to refuse things. And in fact, I saw a lady with MS yesterday where we were with her 2 sisters, and we were able to say, yeah, I'm very happy with you wanting things tomorrow, but she really couldn't imagine what it was like if her MS deteriorated. All we could get was, if my MS is bad, I don't think I want life prolonging, but we couldn't expand, and I thought I couldn't write an ADRT for what happens in the future. That would be wrong. Okay, so I know we're running out of time, and I knew that there was lots to tell you, so I will be around for coffee. So what my advice is, use the patient's words and phrases. It's their document, okay? As much as you can, you know, put lots and lots of things in about them and why they're writing this document and what's important to them. Write advanced statements and refusals separately and make sure they make sense. So if you scan the document, I do want this in this situation, I don't want that in that situation, in two separate statements. So try not to muddle them up. And if you've got, I do want this, you know, but if this happens, you're going to need to split it. Be very specific and use medical language. So although that's not the language the patient's using, we need that for your doctor in A&E or your paramedic. And you don't need to write something about every treatment. So although my proforma has got everything in it, sometimes patients don't want to talk about everything. So either leave it blank, because you'll say, well, if it's a best interest decision, you're happy to leave that bit to chance. But you've told your family enough, so you know what? You can leave that open. And if you can't predict the situation, because we can't predict everything, tell me how you want me to make that decision, how you want the family or the doctors to make that decision. And don't actually accidentally sign the patient out of treatment. This is your blanket. I don't want this in any circumstances. It's our role to think about the circumstances. And then what about review dates? Okay, so if you're going to write an advanced decision to withdraw treatment, it needs to have on it obviously the patient's name, NHS number, date of birth, address, GP and contact number. It needs to have a statement that says, these are my wishes on whatever date. These wishes stand even if my life is at risk. And that helps you decide that that patient had capacity when they made this decision. Okay. But we don't have a set review date, as far as I know. So you could put a review date in a year, but what's the problem with that? They forget to do it, so it runs out. So if you see someone a year and a day, if it was in a way, it probably doesn't matter if it was lots of advanced statements, because it's still a best interest decision. But if it's an ADRT, you can't follow that. Can you follow that ADRT reliably? So I will say either have a 3-year review date, or a review date when I know that they're not going to be here. Or I will say indefinite. Now, if I put indefinite, you can still come back at any stage. And obviously, this document only comes into play when the person's incompetent. So anytime you can come back and we can write it, and we'll do version number 2, get rid of version number 1, tell everybody, and start again. But it just means you're not going to get that. It's going to run out. Okay? But that's my practice. Okay? So then lastly, but again, we can think about this, maybe talk over coffee, which are patients who are already incompetent. Of course, you can't write an ADRT or an advanced statement. If they're, you can try, maybe you can write for some things, but you're unlikely to get a very big document. But that's when we write care plans, and these will be things like seizures or infections, where there's been a best interest discussion that maybe we're trying to keep the patient at home. So there's a whole load of things in there, again, and it's about our colleagues in the community. What do they need to do, and can they leave this patient at home safely? And I know there are lots of different documents in different areas, but this is a clinical plan. What do I want you to do clinically, not just medico-legally? Okay, and it will be the background to the plan. So this is a plan that we've used. I've changed the names, and it goes on to say, what do you want to do if an infection happens? And the answer was, or antibiotics via the PEG, using a fan, giving extra fluids, sponge baths, and keep this person at home. And equally, there was a plan for midazolam via the pump, via the PEG, and then subcut midazolam if the district nurses were called out or the paramedics were called out. Because as soon as you got the DNs or the paramedics involved, then hospital admission was going to be on the cards. So we had to write the next bit, which was to keep this person at home. Okay, so unintended consequences, this is my last slide. What are you going to do? You get this call, I had this call, with the following. It actually came from the GP. The paramedics rang the GP and the GP rang me. What do you suggest? So we can't assist a suicide. No. So we've got a duty to treat, have we? Yeah. Okay. What's the muddliness? What's going on with this? What have they got wrong? No, it's not. So is it likely to be in his ADRT where I've written, I'm going to take an overdose, and when I take my morphine and when I take my oxycodone, I don't want to be admitted to hospital? Is that likely to be in his ADRT? No, because it's got to be applicable to the situation the patient finds them in. So that's the whole point of tying it to the UTI, to the pneumonia, because not only has it got to be valid, meaning that you're sure the patient's competent and you have all the right bits written down, that even if my life is at risk, but it's got to be applicable to the clinical situation. So that is not in the ADRT, and get him to hospital, okay? I know he doesn't want to go, but that's not the point, all right? And, you know, we also don't know what's happened, whether he has taken OxyContin overdose. So it's really not good practice at all to leave him there and find out. So he went in, and he came back and was absolutely infuriated that he'd been in. So we redid his ADRT, didn't put taking excess tablets on it, but wrote a care plan. So put in a clinical care plan of all the things that might happen, and saying it's okay, you can leave him at home. And again, he gets delirious. Friends come to see him, and they call for help. Paramedics arrive, and of course, bearing in mind they were there last time, they're not sure whether to follow his ADRT and advanced care plan and want a second opinion. And it's on a Saturday. What do you suggest should happen? So they've rung the hospice.
But someone needs to review him, because he could have a kind of minor infection that could be treated. You've got no evidence that he's actually taken anything. And if he's had a suicide attempt before, there'll be minimal supplies.
Yes. There was absolutely minimal supplies. Yep.
Sorry, minimal supplies.
Yep.
You would be able to have a record of how much medication he hadn't had.
Yes.
So I think it's kind of doing that examination, you know, as you've got temperature or any other signs of infection.
Yep.
And then going back to the forms, is, you know, would you want to be treated for a minor infection?
Yeah.
Or not?
Yeah.
That makes sense.
Yes. Absolutely. So he needs a clinical review. We were absolutely certain this wasn't an overdose because, in fact, following that previous episode, he had, dot therapy. So he was witnessed, the carers were witnessed him taking his medication, and there wasn't a supply that he could get to, and he was bedbound. So if his meds weren't in his bed, he could not get them. So absolutely, he needs a clinical review because he's in danger. They're obviously worried about admitting him, and is he dying or not? Does it fulfill, is it applicable now? Having got it wrong before, is it applicable now? And so what happened was the GP, on-call GP, was asked to come out. One of our hospice nurses was available to go out, and they arrived at the same time. And the agreement was, yes, he was dying from sepsis. He also had chronic renal failure, had been in chronic retention, but didn't, when his catheter fell out, absolutely didn't want his catheter back in. So hence the care plan was, you know, do not send him into hospital for a suprapubic or a normal catheter, because he does not want this. And he died at home, and he stayed where he was, and he was comfortable. So, you know, these plans are wonderful, but you can imagine, you know, it is, as a healthcare professionals not involved regularly with the patient and not seeing these regularly, they do cause anxiety, and they still do need that little bit of extra backup. Okay, so I'm going to leave it there. I know we're running a few minutes late, but I'm very happy to share documents. And my thought was, you know, we could write a very disease-specific, because my document I use is for everybody I see, but we could write one that's specifically for MS, actually, that we could then share. So if anyone wants to do that with me, please contact me. Okay.
Thank you very much.